on to our next speaker, Dr. PALLAVI Prabhu, who's a senior consultant of Shushrita, rather a co-founder of Shushrita Eye Hospital, and from Samrajpura, Mysore. And she's going to tell us something interesting and important. On to you.
Yeah, warm welcome to everybody.
Can you share?
Yeah, a warm welcome to everybody. I'm starting to play now.
A warm welcome to one and all. I had a 60-year-old patient with a hypermature cataract with a calcified anterior capsule and a very small pupil. I had 3 to 4 challenges during this case. After making a main port and a couple of side ports, I stained the capsule with trypan blue to help me aid during my capsule rhexis. As you see, the pupil was very small, so I thought of doing a pupil stretch. I used Kuglins, I did a vertical stretch, and now I did the horizontal stretch. In spite of doing the stretches, the pupil was not dilating well. So I thought of using a B-hex ring or a iris hooks. This was my second challenge. I chose an iris hook as I thought if there was any zonular weakness, I could help my capsule to support with the iris hook. I ended up using 4 iris hooks. You can see the anterior capsule, there it was wrinkled and had a calcified areas. I started the rhexis with the cystitome, but I could not get an edge to start my rhexis. So this was my third challenge. I used a vanas to make a nip into the capsule. Finally, I found an edge where I could start the rhexis. I thought it was going very well. I was able to maneuver over the calcified areas, and also the liquefied cortex was coming into the AC. As I continued with my rhexis, in the superotemporal area, again I got stuck. I didn't know what to do exactly. I did a centripetal traction. I was not able to complete the rhexis. Finally, again I used with the help of vanas, I was able to complete the rhexis this time and remove the anterior capsule. Once I did this, my last challenge here was the management of the nucleus. The nucleus didn't have an epinuclear plate, so it was freely floating. As per routine, I wanted to divide into small pieces and do my emulsification. I was not able to do so. I ended up doing a direct phaco chop and break the nucleus into small pieces. As you see during the emulsification process, as it was freely nucleus, most of the time it was coming into the anterior chamber. But in spite of that, I was able to complete the emulsification. This patient had chosen an IQ package. IOL, I inserted the IOL. The inferior haptic did go into the back. And here I wanted to nudge the superior haptic. But I did have a little difficulty because of the irregular tear. But with a little bit of manipulation, I was able to nudge the superior haptic into the back and able to rotate the IOL well. After the surgery, I was giving a wash. I still was unhappy with the capsular tear which was there superiorly. I thought of trimming it, but ended up giving it up as I thought it was not into the visual area. This patient on post-operative day 1 had a vision of 6/24, and by day 7 she had 6/9 parts. As a panelist, I wanted to know your opinion, how I could have done the surgery in a much better way. Thank you so much.
Very well done surgery. Very well done. A very challenging case at that.
With the hypermature cataract with the calcified anterior capsule.
Yeah. Very challenging case and very well dealt with. So lax posterior, lax capsule, you could have thought of placing a CTR, but you can't do it because you have a rhexis extension in this case. So that is not there. Maybe an IOL scaffold could have been placed when you have
Pupil was very small. So I thought of doing a pupil stretch. I used Google Lens. I did a vertical stretch.
And stop sharing. Yeah. Could it be that you could have used an IOL scaffold, which could have kept the posterior capsule taut and well away, and because there's no epinucleus protection also in that case. And then with the rhexis extension, I don't think a my loop could have been used. These are just my thoughts when I see this video. Well managed. You have to have some discussion, so I brought up these issues. Dr. Basin, you have anything to tell?
Yeah, it was a very challenging case which she has shown. I really appreciate her efforts. And the thing is that what I prefer in such a fibrosed anterior capsule cases is that I use micro forceps and micro scissors and a curved micro scissor. So this gives us this cuts the capsule in a circular fashion, like our capsular axis. So this is what I will, instead of using a routine Vanna scissor, I use a micro scissor. So that gives a better control. Secondly, coming to the near the end where she has left the anterior capsule edge over there. So there also we can make another side port at that place from where our micro scissor or my Vanna scissor can go inside and cut that scissor close to the area where the fibrosis ends and in the area where the normal capsule is there. That should be the way to go in such cases, and it should be very close to it. It should not go beyond it. And she was lucky that while pulling the capsule, doing the capsular axis, that didn't extend to the periphery right at that particular moment. Yeah. So this is what, and we should not pull it. The moment we find that there is a resistance, it is not going further, to bring in the scissor, cut at that particular place. Try it if it is able, if you are able to continue. Otherwise, you cut it with the scissors, and circular opening can be created. Coming to the nucleus management, that is a big challenge in such a cataract when the nucleus is hard enough. So the high viscosity viscoelastic will help us, and in such a cases which will distend the bag as well as deepen the anterior chamber. And high vacuum phacoemulsification should be done to engage the nucleus. Otherwise, if you are finding it that you are taking it not like a challenge or taking it, you are afraid of it, you will not hold the capsule, the nucleus, and the chances of damage to the endothelium is more in such a situation. So high vacuum, and your phaco tip was also not towards the nucleus; it was up. I don't know how it has happened. It was there when I was seeing the video in your case. So the phaco tip, the side of the tip, which should be down, and that was slightly, it was on our upper side. That's what I observed. But anyway, and is well, I really appreciate to bring such a challenging case for the discussions here.
Dr. Sanjay, one more from you. Dr. Sanjay Chaudhary, any comments?
Yeah, okay. So in this situation, I would say the challenge is basically the anterior fibrosed capsule.
Yes.
And how to handle it.
Yes.
We know that a needle will puncture the softer areas, but it cannot cross over to the fibrosed areas. Yes. That is very clear. The fibrosed areas have to be cut. And to cut that, you need a fine curved micro scissors, which Dr. Purinder was talking about.
Yes.
So now it's the combination of needle and scissor all along till you get a central opening. Because anytime you try to pull at the fibrosed area, the pressure will cross the fibrosed area and run off to the periphery into the softer anterior capsule.
Yes.
So that maneuver has to be avoided. Just keep cutting, pulling, and just make a sufficient rhexis of your size. And even if it's a hard rhexis, non-stretchable rexes, it really doesn't make any difference as long as you get a 5 millimeter opening. In fact, at one time, I tried the Zepto technique. I felt that that wire could burn the fibrous capsule, but it burned the softer ones, but not the harder ones. So even that didn't work too well. So it's only the scissor and the needle combination that works.
A vitractor also can be tried in
Exactly.
those
I
areas.
was just thinking about that. Could
A
we try a
vitractor can be
vitractor
tried.
and cut
Yes,
those edges
So we
where
are-
she was struggling in the end?
yes, yes. And one more thing, Dr. Pallavi, lovely surgery. But when you are cutting it, you were using only one hand. You should, or if probably it was stabilized with the forceps in the other hand, then it is more controlled.
Yes,
And wherever you are pulling, it should not be too far from the area where there is a tear.
yes.
Otherwise, it can easily go out of control, and whatever fluid was coming out, you can evacuate, fill it with viscoelastic, deepen the chamber, then it becomes a little more
Yes,
controlled.
it was a more challenging case, as you were saying, and I was trying to do it. I also thought of using a vitractor to cut the capsule, but at the end of it, I gave it up because it was not in the visual axis. I thought of leaving it.
Jen wants
Dr.
to-
Arun Jain, you have anything to add?
Yeah, so we have done like in this case, the at the end of the axis, you could see two bands going towards the periphery. So, and like everyone has said, we should be using curved micro scissors. So it may be little difficult to cut in that area. You have to go from some inferior or below 3 o'clock or 3 and 9 o'clock meridian. So we have done many cases with Vitractor. We have even sent a for publication also. We have used Vitractor in such cases because once we keep pulling on the fibrous band, it will usually run off to the periphery. And as far as heating up the nucleus is concerned, in these cases, because it's a sort of hypermogregian cataract, there's a very hard nucleus. We use a soft shell technique, and to stabilize the nucleus, we fill up the bag with methyl cellulose so that you have a tamponade. And because even in these cases, the capsule is also very thin and fragile, and little fluttering, and it touches the tip, you are gone. And like you said, the initial case, you have to do a direct chop with the face of the tip down so that you get a good grasp on the nucleus, bury into it and do a direct chop, make into 4 pieces. That's how we do it. And in case you are too much worried, IOL scaffold is the best technique to follow in such cases. That's how we do it.
Very much,
We
Dr.
sent it for publication. The Vitractor assisted.
Yes.
Yeah.
Thank
Will
you.
a vitractor work to cut the fibrous anterior capsule? That is the question.
Yes.
Yeah, because in such cases it is not too thick. But if you see very long-standing uveitis cases, there, depending on the duration of inflammation, it will become too thick. And most of the time, you see the plaque is resected to the center. Only, even in this case, only at that superior margin, it was two bands were extending. So at that point, either she should have cut it with the Vanas or a curved micro scissor or a vitractor, because the moment we pull on the fibrous band, the rexes extend in the thinner part of the capsule into the periphery, and it may go around the zonules to the posterior capsule. So to avoid that, we do all these observations of using microvitractor, soft shell technique, and keeping the second instrument always in front of the nucleus to prevent the budging of the nuclear pieces against the endothelium, so that you get a crystal clear cornea the next day.
Thank you, Dr. Arun. We shall now thanks Pallavi.